All right, so welcome back. For this lecture, we're going to be talking about the sheep brain dissection and also just basic components of neuroanatomy that you should be familiar with for the purposes of medical physiology. And again, my name is Dr. O. Clarkson. You can call me Dr. O or Dr. Clarkson, either which way works. So let's go ahead and jump into it. So in terms of overview, these are the terms that I expect you all to be very, very well acquainted with. So dura mater, arachnoid mater, those are going to be the outer layers protecting the brain. Pituitary gland is going to be one of the main glands on the ventral surface of the brain. I'm going to expect you to know the difference between sulci, gyri, as well as fissures. We're going to talk about the different lobes of the brain, so the frontal, temporal, parietal, and occipital lobe. And then we're going to go through cranial nerves 1 through 6. We're not going to go over cranial nerves 7 through 12, mostly because for the sheep brain dissection, once we remove the dura mater, unfortunately, the dura mater takes along with it the majority of the remaining cranial nerves. And quite honestly, we're only going to really be seeing cranial nerves 1 as well as cranial nerves 2, just because those are some of the most larger cranial nerves that you'll find in the brain overall. These are other terms that I expect you to know, so we're going to go over those throughout the course of this lecture, so you can review that at a later time. Other terms that you need to know are going to be the subcomponents of a neuron, so that's going to be the dendrites, the cell body, the nucleus, axon, Schwann cells, myelin sheaths, nodes around Vier, and axon terminals. And hint, those may or may not show up on your midterm or final exam. So keep that in mind. And then we're going to talk about the spinal cord, the dorsal versus ventral root ganglia, as well as the white matter versus gray matter. So this is a really cool table that shows the overall function of the central and peripheral nervous system. So, for instance, down at the very bottom left, it shows you the inputs of your nervous system. So those are going to be your receptors, and that's going to be your sensory, predominantly sensory receptors and inputs. So those are things that are going to include smell, taste, balance, vision, hearing. So you hear a sound, how does your body react to that? You taste something, how does your body react to that? You smell something, again, how does your body react to that? So that's going to be your special sensory receptors. Then you also have visceral sensory receptors that are going to be within your viscera. And think about what viscera means. When someone's eviscerated, what does that mean? Their internal organs are removed. Visceral sensory receptors are going to be the receptors that monitor your internal organs. And then you have your somatic sensory receptors. Somatic meaning body, soma. Those are going to be your muscles, joints, skin surface. So those allow you to monitor the ways in which your muscles are contracting, the way your joints are being moved, as well as the way in which you're experiencing sensations on your skin surface. The next section over here involves your peripheral nervous system. So these are outside of your control, right? So you have two different sections of your peripheral nervous system. You have your afferent division as well as your efferent division. Afferent, think A, that's going to be the first letter of the alphabet. That's going to be the things coming in, and E is going to be the effect. So think A, afferent, where the information is being brought within the central nervous system, and it's going to result in an efferent effect onto your peripheral nervous system, which is going to affect your end effectors, which we'll talk about in a second. So peripheral nervous system, also known as PNS for short, that's going to have afferent fibers going to cause some form of physiological response in your central nervous system. Central nervous system encompassing both your brain as well as the nerves within your spinal cord. And so that's when you integrate, process, coordinate all the different data that's going to be allowing for an efferent effect. So efferent nervous system is going to be divided into two different sections. There's going to be a somatic nervous system, and that's going to be your effectors. So the effector branch of that section of your nervous system is going to be your skeletal muscle. So that's going to be like voluntary skeletal muscle. You have a peripheral, like for instance, you touch a hot plate all of a sudden that pain stimulus is going to result in a peripheral nervous afferent signal that goes into your central nervous saying, oh my God, alarm, danger. We need to remove this hand from this plate so that we don't get some serious third-degree burns. And that's going to result in an efferent effect that's going to cause your skeletal muscles to contract and remove your hand from a scalding hot plate so you don't burn yourself and cause some serious tissue damage. So that's going to be your somatic nervous system. So somatic is going to be mostly within your control. And then the autonomic nervous system, which is outside of your control, autonomic, is going to be subdivided into the both parasympathetic nervous system as well as the sympathetic nervous system. Parasympathetic, PNS, is going to be the shorthand acronym, and then sympathetic, SNS. The PNS is going to be what regulates smooth muscle contractions, cardiac muscle, as well as glandular effects. Adipose tissue is going to be the only effector tissues that are going to be associated with the sympathetic nervous system. All right, so there are going to be a couple main regions of your central nervous system, of which include the cerebrum, which is going to be everything involving your cerebral hemispheres. So you have both right and left cerebral hemispheres that is divided sagittally down the midline, right? And then you have your cerebellum, which is going to be the section of brain that is sitting ventrally underneath the cerebrum. And the cerebellum is going to be associated with things like balance, things like proprioception. We can talk about that a little bit later, but that's going to be your cerebellum. A lot of like involuntary type of ways in which you can monitor the way your skeletal muscles are controlled. Then you have your brainstem, which is also part of your central nervous system, and then your spinal cord. Some big terminology that you should be familiar with are the difference between fissures, gyri, and sulci. So gyri are going to be the protrusions that come out of your brain. So your brain, in order for your brain to have maximum amount of surface area, you're going to have like these little crevices, right? Like little peaks and canyons. And the peaks are going to be called gyri, and the canyons are going to be called sulci. And then occasionally you're going to have a really, really big canyon, and that's going to be called a fissure. So the fissure that's labeled here, for instance, is called the Sylvian fissure, which separates the temporal lobe from the parietal lobe, and the frontal lobe as well. And then the brainstem is going to be subdivided into the midbrain, the pons, as well as the medulla oblongata. And then, we're going to go into details moving forward here. So the cerebrum, as I said earlier, is divided into the right and left cerebral hemispheres. Then you have the gyri, which are going to be ridges, sulci, the grooves, or you can think of them as peaks and canyons. And then you have the central sulcus is going to be the main sulcus that divides your frontal lobe from your parietal lobe. And then you have the lateral sulcus, also known as the Sylvian fissure, which divides the frontal lobe from the temporal lobe. And then you can see a little bit of the midbrain, which consists of pons and the medulla oblongata. All right, so let's talk about the protective layer that surrounds the brain. So there's going to be two main ones that we're going to talk about, and that's going to be dura mater, which literally translates to tough mother. It's a very, very tough fibrous layer that sits on the outside of the brain that protects the brain, and it's what's going to be found lying closest to the skull. So when we do the sheep dissection, that's going to be the main thing we're going to be removing is the dura mater, and you're going to note that it's a very, very tough structure that you actually need to cut into through with a pair of scissors or a scalpel. And then you have the arachnoid mater, which is going to be the layer that sits directly below the dura mater. And the arachnoid mater, think spider. I like to think of the arachnoid mater as like containing the subarachnoid space, which kind of looks like a spider web if you look at it. So think arachnoid, arachnophobia, arachnoid mater being the layer that sort of houses the subarachnoid space. And this is going to be the region in which you're going to find the production of cerebral spinal fluid. And it's going to be flowing through the subarachnoid space, and it's going to be going into the meshwork of trabeculae. And the CSF is going to be exiting the subarachnoid space into the bloodstream through these little outpouchings called arachnoid villi. All right, so moving on. So as I mentioned earlier, there's going to be the canyons, and there's going to be the peaks and canyons. So the peaks are going to be the gyri, and the canyons are going to be the sulci. So gyrus, those are going to be the bumps found on the surface of the cerebral cortex. It makes up all the gray matter for the most part, which the gray matter consists of the nerve cell bodies, as well as dendrites. The reason why we have this gyrus and sulci is just because in order for your brain to maximize its ability to do what it does, it needs to be able to reside within a limited amount of space. So it's going to be confined within the skull, which obviously is a space-limiting feature. So you want to be able to maximize the surface area. So that's why you have these gyri and sulci. And as I said, as you see below, larger sulci are going to be called fissures. So the longitudinal fissure, which is a gigantic sulci that divides right and left cerebral hemisphere, is going to be the area that divides both left and right cerebral hemisphere, and then it's going to be connected by the corpus callosum. The corpus callosum is going to be that large body of nerve fibers that connect both left and right cerebral cortexes. So a really interesting thing about the corpus callosum, which I think we'll be talking about a little bit later here, but the corpus callosum, it connects both cerebral hemispheres. And under certain circumstances, the corpus callosum can actually be dissected. And so there's a condition, it involves epilepsy that is refractory and cannot be treated properly. And so the way in which they treat these refractory epileptic seizures is by going ahead and severing the corpus callosum in half, so that whenever a person's having a seizure, for instance, like grand mal seizures, that seizure is only going to be isolated to one section of the brain. And so there's a really interesting phenomenon that we're going to talk about a little bit later involving split brain phenomenon, so that you have both right and left cerebral hemispheres doing kind of their own thing. They have like their own personalities, they have their own goals, they have their own desires and functions. And so you have these weird split brain phenomenon from these corpus callosum dissections, which we're going to talk about a little bit in the future here. So let's talk about the different lobes and what they do. So the frontal lobe is going to be, of course, judging by its name, going to be in the front of your brain. So it lies directly below the forehead. So that's going to be the region called the prefrontal cortex, right? The cortex prefrontal, it's going to be at the very front of the brain. And the frontal lobe goes all the way back towards the central sulcus. Unfortunately, the frontal lobe is going to be the most common region for traumatic brain injuries. And that's very pertinent because the frontal lobe is going to be involved in personality, emotional expression, problem solving, memory. It's kind of all the higher executive function that your brain is responsible for. So whenever you do have damage to the frontal lobe, you're going to have problems with your executive function. And then the next region is going to be your temporal lobe, which is going to be residing directly inferiorly to the frontal lobe. It's kind of behind the ears, and it is the second largest lobe, and it's going to be processing auditory information and encoding memory as well. The temporal lobe additionally contains the primary auditory complex. So if you have any damage to the temporal lobe, you might have damage in being able to hear properly. Not necessarily, so probably like processing audio information, auditory information, etc. It's also associated with understanding language, memory acquisition, face recognition, things of that sort as well. Again, we were talking about frontal lobe damage being associated with your higher executive function and emotional function, behavior, things of that sort. And so that can be demonstrated really well with the case of Phineas Gage. So Phineas Gage was a railroad worker. During his job, one of the spikes that were being placed out into the field, dynamite wasn't going off. So he had to go out there to inspect what was going on and to see what happened. And so he tapped on this railroad spike, which unfortunately triggered the stick of dynamite to actually go off, sending this gigantic metal steel rod through his frontal lobe. He got knocked down, but stood right back up and was actually able to function because it was just his frontal lobe that was knocked out. None of his motor function was knocked out, and other essential functions associated with, for instance, the autonomic nervous system. So he was able to, kind of be relatively normal after his accident. But, however, immediately in the aftermath of his accident, he started having these really weird emotional outbursts. So, his doctor, for instance, talked about how he became fitful, irreverent, indulgent at times, extremely profane, and impatient of restraint, and he wasn't able to take advice, and vacillating emotions, etc., etc. But when you hear people talk about the case of Phineas Gage, a lot of people talk about how frontal lobe damage can be a permanent phenomenon. So if you have permanent behavior changes from frontal lobe damage, that's something that's going to stick with you forever. But no one really talks about how Phineas Gage eventually started to normalize over time, and that's because of neuroplasticity, where different neurons start coming in and taking over where other neurons were damaged or destroyed. And so Phineas Gage eventually started to become more of, acting more himself over the years, which nobody really likes to talk about. They really like to focus mostly on how his emotional damage and other sequelae from his accident were permanent features of his character moving forward. But that wasn't exactly true or the case. But it was a very interesting case demonstrating how the frontal lobe does have a huge impact on our emotional temperament and things of that nature. So parietal lobe. The parietal lobe is going to be what's responsible for sensation, touch, pain, etc. So sensation, perception, and integration. Also taste, hearing, sight, and smell. So if you look over here to the right corner, you're going to see two different sections of your frontal and then parietal lobe. So the prefrontal gyrus, which is going to be the red region over there, prefrontal, meaning towards the front. That's going to be your motor cortex. And you see how you have these little exaggerated lips, face, hands and feet, etc. That's what you call a homunculus. So there's two different ways you can draw a homunculus. You could draw it in the sense of the motor cortex or the somatosensory cortex. And the somatosensory is going to be associated mostly with your occipital lobe, and that's going to be the way in which your sensory input is going to be processed through your brain. And so, for instance, if you look over to your left on the somatosensory cortex, you see that your tongue, your gums, your lips, your face, those are going to be really exaggerated senses because your cephalic region, your head, face, neck, etc., those are going to be very sensitive regions because obviously it's going to be the regions protecting your brain. And then you have your hands are going to be kind of exaggerated, right? Large fingers, large palms, etc. And then you look down at your thorax, and your thorax is kind of underrepresented in the somatosensory cortex because pain and sensory input going into your thorax isn't as important as it is when you take into consideration how important it is to protect your brain and your central nervous system, which is going to be around your skull, so your eyes, face, lips, teeth, etc. Then your occipital lobe is going to be the region that is mostly responsible for analyzing visual information. So it's literally the quote-unquote eyes in the back of your head. So visual processing and also visual spatial processing. So that's going to be like depth perception, etc. Also color determination, face recognition, and that, of course, plays into memory formation as well. All right, so let's get into the cranial nerves. And like I said, we're mostly going to go over cranial nerves 1 through 6, but during the dissection, we're going to be talking mostly about the cranial nerves 1 and 2 because those are the ones that are going to mostly remain after we remove the dura mater. So cranial nerve 1 is going to be your olfactory nerve, and that's going to be the one over here, sitting directly inferior to the frontal lobe, and that's going to be responsible for your sense of smell. So olfactory bulb, that's going to be sitting at the very back of your nasal cavity. It has receptors for all sorts of different sensory inputs in terms of smell, and that's going to be your olfactory nerve. So cranial nerve 1, and then cranial nerve 2 is going to be your optic nerve. And if you see the optic nerve on the image, it sort of bifurcates at the optic chiasm, which sits directly anteriorly to the pineal gland. So that's going to be the optic nerve bifurcating at the optic chiasm, which goes all the way back eventually to the occipital lobe, where visual information can be processed. Okay, so moving forward, that's just going to be sort of like for your information. The way in which the optic nerve bifurcates, you have different visual fields going into your eyes. And so we're going to actually go into like what optic nerve damage might look like. So if you follow these lines over here, for instance, if you have a pituitary gland tumor, and as I said, as you see in the image, the pituitary gland sits directly posteriorly to the optic chiasm. So if a pituitary gland tumor is beginning to impinge upon the optic chiasm, what regions of the visual field are going to be affected the most? So take, for instance, the lines that are coming in above at this image. So you have light coming in, and they sort of like cross over, right? So the information coming in from the medial regions are going to be going towards the lateral area of your retina, and then the regions of the visual field that are coming from the temporal area, which is going to be laterally, are going to be coming in through the medial regions of your retina. So if you follow the lines down, try to think of what areas are going to be mostly affected if you had a pituitary gland tumor. So it's going to be your lateral peripheral view. So those are going to be the regions that are coming in from your temporal regions, right? So this is kind of what we will be seeing when we do our dissection. You're going to see the olfactory nerve, which is going to be these nerve fibers extending from the frontal lobe. And then you're going to see the optic chiasm, which is going to be where the optic nerve bifurcates. And here are some other nerves that you should be familiar with. So the ocular motor nerve is going to be movement of the eyes, constriction of the pupils, as well as focusing the eyes in different positions, and movement of the upper eyelid. So if you had damage, for instance, to the ocular motor nerve, you might have like ptosis, which is drooping of the eyelids, or diplopia, which is going to be double vision, and then paresis of eye adduction, or the inability to bring the eye in, right? So adduction, so you can't add the eye or move it towards the midline. So you might get a little bit of this upward and downward gaze. Pupils, if they're affected, they might be dilated, so you're going to have an impaired light reflex. So that's just kind of for your own information. You don't really need to know this for the purpose of the exam, but it's good to know that the ocular motor nerve, ocular motor, so that's going to be the movement of the eye muscles. You also have the trochlear nerve, which is also going to be associated with the movement of eye muscles, and that's going to be responsible for moving your superior oblique nerves, which are responsible for the rotation of vertical plane. So, for instance, if you tilted your head from side to side, your ocular motor your trochlear nerve will be coming into play, helping you move your eyes so that you can see a horizontal plane of field. Whenever you move your head sideways, it's not like the whole entire world tilts on its axis. Like, you're actually able to see the world sort of relatively horizontally as it normally is. even though your head's moving, tilting laterally. So that's kind of what the trochlear nerve does. Trigeminal nerves. So there's two different nerves that are associated with your facial nerves. So there's trigeminal nerves, and there's going to be your facial nerves. So cranial nerve 5 is going to be your trigeminal, and then cranial nerve 7, which we're going to talk about in a second here. Sorry. Oh, actually, no, I take that back. We're not going to go over that for this 1 through 6. But a good thing to know about 5 versus 7, I always think of cranial nerve 7 as the nerves of expression. So those are going to be the motor nerves for your face. So your ability to smile, frown, move your facial muscles, etc. And then cranial nerve 5 is going to be the nerves that are associated with sensory input. And so you have different 3 subsections of cranial nerve 5. You have the ophthalmic nerve. Then you have the maxillary nerve, which sits in the sentinel, and then you have the mandibular nerve of cranial nerve 5. And if you have any issues with these nerves, for instance, you can have trigeminal neuralgia, which is a really, really awful condition, often associated with different, it's mostly associated with conditions such as multiple sclerosis, which is the demyelination of your nerve fibers. Trigeminal neuralgia can result in extreme severe facial pain with things as simple as like a brisk gush of wind, but it can also come about through like chewing, speaking, brushing the teeth, etc. And this is not going to be on your test, but you can treat these types of conditions with drugs such as gabapentin, phenytoin, carbamazepine. Those are some of the main anti-epileptic drugs. You can also do like surgical ligation of the trigeminal nerve. You're not going to be able to feel your face, but at least you're not going to be able to, at least you're not going to be experiencing severe facial pain either. And then you have the abducens nerve, which is going to be the nerve that also works in movement of the eye muscles. So that's going to be the muscle that innervates the lateral rectus. So that's going to be the nerve that allows you to move your eyes laterally. All right, so now let's talk about, so we just talked about the cerebrum, right? The different areas of the cerebral cortex. Now let's talk about the midbrain. So you have the midbrain, which is going to be, the brainstem, which is going to be midbrain, pons, and the medulla oblongata. Hold on a second. Okay, so we're going to talk about the brainstem a little bit later in this lecture, but let's go into the ventricles of the brain first, and then we're going to get into the different regions of the brainstem. So sorry about that. So the only ventricles that I really want you to pay attention to for the purpose of this dissection are going to be the lateral ventricles. So that's like 4th and 3rd ventricle. And the 3rd ventricle is going to be the region directly below the lateral ventricles. And then the 3rd ventricle is going to continue on into the cerebral aqueduct, 4th ventricle, and then down into the cerebral canal in your spinal cord. So something that you might be able to see during the sheep dissection is if we do a sagittal dissection of the brain, you might be able to see the septum pellucidum, which separates both right and left ventricles. The ventricles of the brain contain cerebral spinal fluid. That's the main takeaway point of the ventricles. And this isn't going to be on your test, but the way in which your 3rd ventricles communicate with the other ventricles is through a couple foramen. And foramens just mean windows. And so you have the foramen of Monroe that allows the lateral ventricles to communicate, and then they communicate into the 4th ventricle through the aqueduct of Sylvius. Not pertinent to the purpose of your exam, but just kind of interesting to keep in mind. So this is kind of an overview of everything we went over, the different portions of the cerebrum. We went over that corpus callosum. And then right below the corpus callosum is going to be the thalamus, the pineal gland, and then the hypothalamus, pituitary gland, and then we're going to see the midbrain, pons, and spinal cord. So back to the corpus callosum. Remember we talked about that earlier? The corpus callosum connects the left and right cerebral hemispheres, and then you have the thalamus, hypothalamus, and pineal glands. And those are going to be the different regions of the brain associated with the release of different types of hormones. So, for instance, adrenal corticotropin hormone is going to be something released by the hypothalamus pituitary axis. Other hormones are going to be released through the pituitary, like, well, we're going to talk about it in a second here, so let's move forward. As we talked about earlier with the corpus callosum, it's a big bundle of nerves that connects both brain hemispheres. It can be dissected in a surgical procedure called a corpus calostomy, treating refractory epileptic seizures. We already talked about that. Very fascinating cases that you can read about on your own terms. Not exactly something we're going to talk about for the purpose of your midterm or final exam, but if you look at the split brain phenomenon, that's going to be what you see as a result of the corpus calostomy, where you have the right and left hemisphere sort of taking on their own personality. Like, for instance, a patient might be putting on a shirt. It's a shirt they want to wear, but then like one brain hemisphere says, no, actually, I don't want that shirt. And they start removing the shirt and then putting it back onto the hanger, things like that. It's actually quite interesting and fascinating to see how the different sections of your brain have their own individual personalities. So let's talk about the pituitary gland. The pituitary is considered the master gland. It sends signals to all the different organs of your body. It's associated with things like growth hormone, thyroid stimulating hormone, release of thyroid hormones, adrenal corticotropin hormone, like I said earlier, luteinizing hormone. So these are like your sex hormones, follicle stimulating hormone, etc. Prolactin, the hormone that's released when women are lactating or feeding their children. And the thalamus, which is going to be the region directly below the corpus callosum. That's going to be involved in sleep and arousal. Also relays motor and sensory signals to the cerebral cortex. Interesting side note is there's only one sensory input that bypasses the thalamus, and that's going to be coming from cranial nerve 1, which is your olfactory bulb. And one of my theories on that is, one of the most important senses for us is the sense of smell, because you can determine whether or not something is extremely putrid and therefore you shouldn't eat it, right? And so you definitely want to ingrain that directly into your brain and your memory so that it doesn't go through the thalamus. That's such an important sense, your sense of smell, that you want to know, for instance, if something is rotting, whether or not you can eat it. So every other sensory input goes through the thalamus and gets processed in the cerebral cortex. The hypothalamus is going to be associated with autonomic nervous system activity of the pituitary, and it controls things such as temperature, sleep, emotion, sex, childbirth, blood pressure, third, and hunger, etc. The pineal gland is going to be mostly associated with melatonin and driving your circadian rhythm, which is, kind of your metabolic processing, as well as the way in which it's kind of like your internal clock, where you can start figuring out what your sleep patterns are. That's going to be determined mostly by the pineal gland. Okay, moving forward. So let's talk about the brainstem. So at the very top of the brainstem, you have an organ called the superior colliculi, which is primarily going to be integrating visual information, also auditory and some other somatosensory spatial information, but mostly visual. The inferior colliculi, on the other hand, is going to be mostly processing auditory information. And so you're going to be processing, integrating auditory information, as well as like frequency recognition and pitch discrimination. So that's going to be your superior and inferior colliculi. And then you have your midbrain, which is going to be mostly associated with motor movement of the eyes, as well as auditory and visual processing. So that's going to be midbrain. And if you look over to the right, you can see your midbrain is going to be associated with things like your trochlear nerve there. Your ocular motor nerve. You see that? And then moving forward, you're going to see the pons, which is going to be associated with pneumotaxic and it's like the apneustic center. So that's respiratory control. Also associated with rapid eye movement, sleep. So think pons, think sleeping, think breathing, think respiratory rhythm. And it's going to be where you find the nuclei of 4 different cranial nerves. So the pons region over here, you can see, for instance, the trigeminal nerve, which is going to be your nerves of your facial sensation, etc. And then the medulla oblongata is going to be the lowest portion of your brain, the lowest portion of your brainstem, and it's going to be associated with autonomic activity, respiration, as well as heartbeat. So think cardiac function, vasodilation, things like that. Also sneezing and swallowing. All right. Another thing that I want you guys to know about is in the cerebellum, there's an anatomical feature called the arbor vitae. The arbor vitae literally translates to the tree of life, and that's because you have these interesting little branches that look like tree limbs within the cerebellum. So we're going to see that when we cut the sheep brain sagittally, we're going to be able to see the arbor vitae. But the cerebellum is primarily responsible for balance, coordination, speech, but let's think posture. So there's a thing called proprioception. That's the way in which your body is able to figure out exactly where your limbs are relative to your body. So for instance, if you have a patient that comes in and you want to be able to determine whether or not they might have some form of cerebellar damage, you have them close their eyes and stick their arms out. And if they start having pronator drift and your arms start moving with their eyes closed, then you know that they might have an issue of proprioception. So they might have some form of cerebellar damage. All right, so here's the sheep brain. The main things that we're going to try to identify are going to be the corpus callosum, which are the region connecting the left and right cerebral hemispheres. We're going to try to find the arbor vitae within the cerebellum. We're going to try to identify the thalamus, the hypothalamus, pons, medulla oblongata, pineal body, as well as the lateral ventricles. The midbrain, pons, and medulla oblongata, it's kind of hard to differentiate during dissection, but you kind of have to figure out where they might be in relation to each other. That's going to be the best way for you to be able to identify them. And so again, here's an actual image of a sagittal section of a sheep brain. As you can see the different gyri and sulci. You can see where the pineal gland sits. You can see the different colliculi, the superior as well as the inferior colliculi. The cerebellum, the arbor vitae is really nicely demonstrated in this image. And then the different regions of the midbrain. So that's going to be your pons, medulla, etc. All right, so a brief overview of neuron anatomy. What I really want you to know about are going to be the different sections, including the dendrites, which is the regions in which your nerve cells receive information from the axon terminals, and that information is going to be sent into the cell body. You can see the nucleus there, and that cell body is also called the somatic body. And then, unfortunately, this image doesn't show you the axon hillock, which is the region by which you need to receive a threshold of a electrical impulse in order for it to actually fire off a full-blown nerve impulse down the axon. And the nerve impulse is going to travel down the axon. The myelin sheath surrounds the axon in order to create a form of insulation that protects the axon and allows the nerve impulse to be conducted all the way to the axon terminals. And those axon terminals are going to connect with dendrites of other neurons downstream. And so there's going to be the presynaptic cleft, the synapse, and then the postsynaptic cleft. So the presynaptic cleft is going to be your axon terminals. Your synapse is the region in which your axon terminals connect to the dendrites. And then the postsynaptic cleft is where the dendrites are able to send electrical signals down into the soma or cell body. Other areas I want you to focus on are going to be the nodes of Ranvier, which are going to be the regions in which sodium and potassium can be exchanged between different myelin sheaths. And know that the myelin sheaths are made up of Schwann cells. So Schwann cells are those neuronal cells that make up myelin. And here's some more information just for your own studies, not necessary for the exam. And then let's think about white matter versus gray matter. So gray matter is going to be the regions on the superficial layers of the cerebral cortex. White matter is going to be the regions within the cerebral cortex. So white matter predominantly consists of myelinated axons, whereby gray matter is mostly going to be cell bodies as well as dendrites too. But when you start moving down into the spinal column, it flips. You get gray matter on the deeper layers of the spinal column, and then you have white matter on the superficial layers of the spinal column. So it switches. So this kind of goes into more detail about the difference between gray matter versus white matter. So take, for instance, this cross-section of your spinal cord. What's this region on the outside? So the outside is going to be your myelinated nerves. So that's going to be myelinated axons. So that's going to be your white matter. And right there in the middle is going to be the gray matter, consisting mostly of cell bodies and dendrites. And then finally, we're going to go over dorsal versus ventral root ganglia. The way that I like to think about dorsal versus ventral root, so dorsal is going to be towards the back, so that's going to be the areas closest to your spinal processes as well as your transverse vertebrae. So spinal processes, if you touch your spinal cord along your back, you're going to feel little bumps. Those are going to be your spinal processes. And so that's going to be towards closer to your dorsal root. And then ventral root is going to be the area closer to your inner organs, right? So it's going to be more protected by your spinal column. And the way I like to think about which one is sensory versus which one is motor is, what would be more catastrophic if it was knocked out? Would it be motor or sensory? Obviously, it would be better to have your sensory nerves knocked out and still be able to maintain your motor function, because at least you'd be able to still maintain movement. If you had your sensory input knocked out, you would lose feeling and some sensory inputs, but it wouldn't be a huge deal. You could still survive, relatively unscathed. So I like to think of dorsal root as being like the less important of the two. So I like to think dorsal root sensory, ventral root motor. And then this is just kind of an overview of the sheep brain dissection that we're going to go over together next week. And if you have any questions about today's lecture, just give me a message through Halo and we'll take it from there. And I look forward to seeing you guys next week. Take care.